I don't know how fast it takes to start video machines, but actually when they're doing film, it takes a few seconds to get the film going. So there's a moment when they start the camera before you're supposed to speak anyhow or do anything. So, you know, this was like that moment. And there's also a bigger moment when you're supposed to get into character, which takes longer than it takes for the film to start anyhow. So, okay, we're back here, live for some of you and on tape for Bill. To recall where we are, the reason for doing experiments versus controls in experimental design is because we have a problem which is known as the placebo effect. And there was a nice article on this about 2 months ago in Scientific American. And the basic problem is that if we have two groups of people and we just give them a pill, even if the pill has no ingredients with them, 30% of the people get better. So just the fact of doing something to someone causes a result, even though there's nothing going on. And this is a very strong effect. Quoting from a book that I'm going to read more from later in this talk today called Deadly Medicine. So let me read, this is from a book called Deadly Medicine, written by someone whose name I can remember, although not because it's the right person, but Thomas More. This book was published a few years ago, and we'll see a little bit later why it's called Deadly Medicine. He writes, "Not only can physicians remain blinded to direct harm, many patients get better when given treatments that are inert substances of manifestly no effect." In this classic exposition of the placebo effect, quote, "the lie that heals," end quote, Howard Brody of Michigan State University noted that 30 to 40% of patients got better on a placebo. These effects are far-reaching, have been observed in hundreds of separate studies. Dramatic placebo effects are often seen in situations where the prime benefits are subjective. For example, patients given a placebo for panic disorder report fewer episodes. But measurable benefits have been noted among heart failure patients receiving a placebo instead of an active drug. In one 1990 study, 25 to 35% of those getting the placebo reported fewer symptoms, increased cardiac output, and the ability to tolerate increased levels of exercise. In another experiment, the placebo effectively suppressed additional heartbeats in 35% of the patient population with at least 10 premature beats an hour. In many cases, the personal observation that lies at the heart of clinical judgment cannot separate a placebo effect from treatment benefits. So this is the reason why we need experiments and controls. So what we do in the experimental group, we give the real pill, and to the control group, we give this placebo, which looks like the real pill, but contains no medication. And we have to do this because if we don't do this, people just respond and think they're getting better, and so they do get better. So that's why we always need to compare an experiment versus a control group. We can't just do an experiment because what we think is going on in the experiment may not be what is going on, because people are just responding to the fact that they're in the experiment. And we can, this sort of experimental procedure is called a blind experiment, which means the subjects don't know what's going on, don't know which group they're in, whether they're in the experimental or control group. Now this isn't enough because the experimenter can pass on very subtle clues to the people in the experiment about what they're expecting, and that can influence the outcome of the experiment. So for example, in a study done by Rosenthal, where they told teachers that some students in their class had higher IQs than others, the teachers responded more positively to those students and they did better in class, even though there was no difference in IQ between the two groups of students. So people respond to what the experimenter wants. So what we need is another type of experiment called double-blind. In the double-blind experiment, the experimenter doesn't know which subject is in which group. And the way this is done, for example, in a drug study, the doctors giving the drug may give things that have different labels on them, but the labels don't indicate whether it's the real drug or the placebo. And so we need these double-blind experiments to prevent errors from happening in the experiment. And I sometimes say then there's a triple-blind experiment where you don't publish the results, so you don't tell people what happened in the experiment. But I won't say that here now. But these are very important because it's very easy for people to respond to what they think is supposed to happen and what they think the experimenter wants them. The most famous case of this was a study of which there's some criticism recently called the Hawthorne plant effect. And the Hawthorne plant, this was done, I think, right after World War II, was a plant, I think it was near Chicago, but I'm not sure. It was someplace in the Midwest. But I know what they made. They made rotary switches for telephones. And I'll describe a little what rotary switches are. If you remember, telephones used to look like this. You had numbers, and you used to turn this dial. The reason why this existed, and I don't remember the details of the story, but I've seen this in a number of places, so I know this is a real true story. There was a small town in the Midwest where there was a guy who ran a funeral home. And when someone died in this town, they didn't go to his funeral home very often. Almost all the times they went to the funeral home run by his competitor. There were 2 funeral homes in the town. And he couldn't figure out why he wasn't getting business from a lot of people who were dying in this small town. And he finally realized that the wife of the guy who ran the other funeral home was a telephone operator. So when people would call up, there was a human operator who would connect the wires. And when they asked for a funeral home, she would always connect them to her husband's funeral home. So this guy was really angry at telephone operators. And what he promised to do was to invent an automatic device that would replace telephone operators. And this was the guy who invented the rotary dial telephone. And the way these things worked is that it was a gang of switches. So the way the rotary dial works, when you move it forward, nothing happens. It's when you release it, you can hear the clicks as it goes back. And those clicks would rotate in the switching office another rotary switch, and there were actually 2 of them that were ganged together. So actually 2 numbers in a row would be sent. So for a 6-digit telephone number, there would be 3 sets of these. And in fact, now we dial a 1 to indicate a long-distance call, but originally you didn't do that. And the reason why all area codes had a 0 or 1 in the 2nd digit. Okay? And these rotary dial switches were always in gangs of 2. So although we couldn't tell it was a long-distance call from the 1st digit, the 2nd digit, always a 1 or 0, knew it was a long-distance telephone call. And that's why the 2nd digit of area codes were always 0 or 1. Now they're replacing those to create more numbers, because this is very wasteful of numbers. But now to know whether the call is local or long distance, you dial a 1 in front of it. So it's looking for that 1. So a real telephone number doesn't start with a 1 in the front, and the 1 indicates a long thing. In any case, the Hawthorne plant made these switches, these 2 gangs of rotary switches. And this group of psychologists went in to see how they could increase productivity in this plant. And they did lots of different things, you know, like industrial psych people do. They changed the lighting in the plant. They changed the coffee break time in the plant. They changed the colors of the walls in the plant. So they did lots of different things to increase productivity. And what they found that increased productivity was everything. Everything they did increased productivity. And the lesson that came out of this was that none of these things were important in increasing productivity. But the workers liked to think that the management cared about them because they had all these psychologists in doing something. And therefore, they were more productive. So what people like is other people responding to them, and not the colors of the wall or the music or when they took the coffee breaks. And the lesson here is that people respond to the experiment. And it may not be the particular thing you're measuring, but it may be they're responding to the fact they're in an experiment. And that's why we need to have these controls to compare one thing against another, especially in doing these psychological experiments. Now, recently, there's been a revisionist interpretation of what went on in the Hawthorne-Plan effect in an article a few years ago in Science. The article was written in such a snotty way, I had no understanding what they were saying, so I just don't think it was really much of a change from sort of this older interpretation. But this is a very famous experiment. So what I'm trying to show you is how important it is to create these control groups, and that we measure one thing against another and not just do an effect in an experiment. Another example of this is in the jargon word, which you should know in psychology, is called confounding variable. And this means something else goes on in the experiment that normally in the standard psychological paradigm, we have an independent variable and we measure a dependent variable, and we're looking for the dependent variable as a function of the independent variable. And a confounding variable is something that messes up this function. An example of this is, I'm trying to make sure I get the example right, but here it is. Let's say you were doing a taste test between Coke and Pepsi. Well, you can't label them Coke and Pepsi because that would not be a blind experimental design. So this is not cool. So what we would do, for example, what was done in one experiment was to label one of them S and the other one L. And so this is a blind experimental design now. And you can see how often people like the taste of S compared to L better. Okay. The only problem with this is that it turns out no matter which was labeled S or L, Coke or Pepsi, people always prefer the label S over the label L 85% of the time. So for some reason, people like S's better than they like L's. It has nothing to do with which soda is in which thing. And this is called a confounding variable, because something else has gone on with the experiment to mess up the relationship between the dependent and independent variable that we're looking for. And these can be very subtle. This is something I would have never guessed. And it's interesting that people just like S's better than L's better. So how we design an experiment, we've got to be very careful about working with these confounding variables. In fact, this experiment with S and L was done by Woolfolk, Castellan, and Brooks, although I don't have a date of the experiments. Now, let's get back to the relationship between how we handle things in the within group and between group designs. So remember, the difference is that in the within group design, everybody gets all treatments. And in the between group designs, we have different people, subjects, not people, subjects, get different treatments. And treatments is another jargon psychological word. And to go over again the advantages of both of these designs is that the within group design, each person or each subject is their own control, whereas in the between group design we're comparing different people, which so different people get different treatments, and they may be different, so they just may respond differently. So we have your own control in the within group design. Second advantage of the within group design, as I said, we need less subjects. The advantage of the between group, or the disadvantage, say it this way again, the disadvantages, or for the within group design, the disadvantage is what I said, it's called carryover effects. And how do we cure carryover effects? What's the magic word for curing carryover? Counterbalancing. Thank you. See, now you'll all be psychologists. And the disadvantage of the between group design is the thing that I stated up here, and the advantage is that there's no carryover. This is just what I said before, but I want to repeat it because I want to now go into a little detail of how we do the counterbalancing. because there's a standard way of doing this, and I think sometimes it's not explained so clearly. So one way to do the counterbalancing, or the most naive way, would be if we had 3 treatments. So what I'm describing here is how to do counterbalancing. So let's say we have 3 treatments which we call A, B, and C. So I'm going to make a chart now where each row is a subject. And so the first subject receives things in the order A, B, and C. And the next one we can give B, A, and C. Maybe the third one C, A, and B. And then the fourth subject we can have A, C, and B, and B, C, and A, and C, B, and A. And if I'm lucky, I've included all the possibilities. So what we can do is we can have, in this case, 6 subjects, or we might have 12 subjects and do 2 in each one, or 18 subjects, something like this, and give them all the different possible combinations and see if we get the same results. Well, let's say if we had 4 subjects, 4 treatments, not 4 subjects, but 4 treatments, how many different combinations would I need? Here I have 3 subjects, and I have a total of 1, 2, 3, 4, 5, 6 combinations. For 4 treatments, how many different combinations do you think there are? Right, 24. And for 5, it's 5 times 24, which is 20, which is 2, which is 120. So it gets prohibitive real fast. We can't try all the possible combinations. So what we try to do, if there are more treatments, we try some of the combinations, not all. We try some. And this some of the combinations, how we try some, has a very specific name in psychology, which is called what? No? If I give you the hint, you'll instantly get it. So 2 words, and the second word is square. It's called a Latin square. Is that familiar? That's not familiar? Okay, good, because if it was familiar, then you wouldn't need to be here. So that's good. And what we do in a Latin square is we try some combinations, not all, of the treatments. So again, this is a fudge, because it's too hard to do it right, meaning that too many experiments or too many people, it would cost too much. So what we do is we do some combinations to do the counterbalancing. Okay. So let me give you an example. A typical Latin square would be A, B, C, D, B, C, D, A, C, D, A, B, D, A, B, C. So again, each of one of these is a subject, and these are the treatments, 4 treatments that they're receiving. So in this case, we have 4 treatments. And look how this is done. The first one, we start off with A, B, C, D. The second one, instead of starting the first treatment, we start off the second treatment, B, C, D, and then do A. And then here, instead of starting this one, we start one later, B, C, D, etc. Okay, so you see how these are scrambled. And so this way of scrambling it is called a Latin square. And these are described, actually, in the appropriate chapter in Spiegel's book, I think. But let's look at this a little more carefully. Let's look at which treatments follow. What follows each treatment? So you can ask what follows A, what follows B, what follows C, what follows D. So in subject number 1, what follows A? B. In subject 2, what follows A? Well, nothing. In subject 3, what follows A is B. And in subject 4, what follows A is B. Now let's do the same thing for B. So in B is followed by C here, by C here, by nothing here, and by C here. And what follows C? In the first one, D, D, D. And what follows D? Nothing. What follows D here is A. What follows here is A. And so we haven't mixed up things really well, have we? Because the treatments are still happening in the same order. Remember, we've only chosen 4 possible treatments out of 24. So we're only taking a sixth of all the possibilities, and maybe we haven't taken the best sixth. So let's take a different set of 6. And this also has a name. This particular name is called a balanced Latin square. And the balanced Latin square reads A, B, C, D, not surprising, B, D, A, C, C, A, D, B, D, C, B, A. Now if I go through this and look at what follows what follows A, B, C, and D. What follows A here is B, C, D, nothing, C, D, nothing, A. What follows C is D, nothing, A, B. What follows D is nothing, A, B, C. So in this balanced Latin square now, a different treatment always follows the previous treatment. So again, we're only choosing 4 out of 24, but kind of this is a better set. So there are different rules of how we can choose the orders of the treatments to kind of have a better stab at beating the counterbalancing. Okay. But again, I want to emphasize, I think most books don't emphasize that the Latin square is still a trick, because we're still not choosing all possibilities. And we're trying to choose possibilities that are the greatest mixtures of different possibilities. And so the balanced Latin square has some advantage over that in terms of the Latin square. Now, okay. Let me now go on to a concept that's crucial in how we do experiments. And this has a couple of different names. The name we'll give it here. And I'll discuss it in terms of clinical medicine, but the same thing happens in terms of doing psychological experiments. In clinical medicine, it's called the randomized clinical trial. And the idea behind this is that because of these placebo effects, if we just give someone a treatment, we can't assess whether the treatment is really good or not, even if it has a positive outcome, because maybe just giving them the treatment is affecting them, and the treatment itself may not be doing anything. Now, what's interesting about this is I'm going to read to you a little description of an article in Science from 1994. And what they basically say here is they say that about 1/3 of all the articles that are published using randomized clinical trials don't do it right. So what I'm going to tell you now is that a lot of people doing this research mess it up, and that it's very difficult, not very difficult, but it's important to do this right. And I want to give you a sense of how often people do this wrong, which is why you should really understand that it's important to do it right. So for example, they say here about 1/3 of randomized clinical trials published in elite medical journals appear not to ensure that the patients are assigned to different treatment groups by chance. Remember, if we have a between-group study, we have to make sure that if one group is going to get the drug and one group is not going to get the drug, is going to get the placebo, what we don't want to do is put all of the unhealthy people in one group and all the healthy people in another group, because the outcome will depend on who's in the group, not on whether the drug is effective or not. And right here, according to a survey reported in The Lancet in 1990, which is a well-known British medical journal, by Douglas Altman of the Imperial Cancer Research Fund in London and Caroline Dorey of London's Royal Postgraduate Medical School, that defect vitiates the reason that randomized clinical trials were developed in the first place, to prevent bias in how doctors treat patients from upsetting the results. Without randomization, for example, a doctor might put healthier patients on the experimental treatment due to an unconscious desire to see the treatment vindicated. Again, this is the reason why we need double-blind experiments. And they continue. Unfortunately, many common methods attempting to randomization are open to abuse. Take the traditional practice of asking doctors to assign their patients to a treatment according to the order in which they enroll. The first patient goes to the placebo, the second gets the test drug, the third the placebo, and so on. If a physician wants a particular patient in the treatment group, she may simply enroll the patient when the treatment is next in line. According to clinical trialists attending a special session on bias in trials at the 15th annual meeting of the Society for Clinical Trials held in Houston, attempts by physicians to circumvent randomization are not isolated events. They're part of an endemic problem stemming from ignorance, or less often from a doctor's desire to provide a patient with what he believes is the best available treatment. It seems that a lot of people don't understand the basic principles of clinical trials, says Kenneth Schultz of the Center for Disease Control and Prevention in Atlanta. They don't realize how these little things bias the comparison between treatment groups. At the Houston meeting, Schultz reported data showing that the experts' fears about ignorance are justified. Schultz examined 250 reports of clinical trials in perinatal medicine, that means of young children, published between 1955 and actually it doesn't mean, what does perinatal mean? It's neonatal. Near birth. So it could mean before born also. Okay. Published between 1955 and 1992, came up with an intriguing finding. Papers that did not describe safeguards to ensure that treatment allocation was kept secret until randomization was carried out genuinely reported larger differences between treatment and experimental groups, treatment and control groups, indicating that bias crept in and undermined the validity of the results. And they go on to say, describing a number of other problems that these studies have. For example, dividing patients into smaller and smaller groups until I saw an effect, which is not something that you can do. That is, if we have data, this is data. All of these are numbers. May not look like numbers to you, but they look like numbers to me. If we want to look in an effect, if we take smaller and smaller sets of numbers under different conditions, so we get to smaller numbers, more unusual things happen. Remember, that's why we want lots of data to create these Gaussians that things average out. So if we take smaller and smaller subgroups, so instead of looking at people between 50 and 75 years old, we look people between born in January and February who are 50 years old, and between March and April who are 50 years old. Okay, so we look in smaller and smaller groups of people, we're more likely to see differences. So they said in these studies, people could pick smaller and smaller subsets of the data until they found something. You can't do that either. Okay? So the point of me reading this is to show you that a lot of people have no idea what they're doing in terms of these experiments. That it's really important to have well-defined experiments and controls and really follow the protocols of how those experiments are set up. Now, I'd like to talk a little bit more about the underlying theory of these randomized clinical controls. This idea of randomized clinical controls is, first of all, new. It's about 100 years old. And second of all, it's really a difficult concept to understand. And in some ways, I'm actually beginning to believe a little less in this concept than I used to, too. So I think this raises some interesting issues. And I think it raises issues more in terms of medical experiments, but also in terms of some of the psychological experiments that we do, too. The issue is, and I'll read a quote explaining this in a moment, again from Deadly Medicine. We have two conflicting problems here. One is everybody is different. So if I give a drug to you, it may have a different effect than if I give it to me. But the second problem is that it's easy to fool yourself as an experimenter. So if I'm a doctor, for example, Mr. MD, okay, so I'm a doctor now, and I have these patients that come in, and I try to do the best for them, and I try to see which ones are getting better and which ones aren't. It's very difficult to make those judgments correctly about when a medication is really helping someone or not, because I interpret their responses differently. If they're getting worse, I may give them more medication. They may get better, they may get worse. I have to decide whether the medication made them worse, whether they were getting worse by the natural cause of the disease. This is very difficult to do. As a result of this, medicine got involved in doing a lot of things which were complete nonsense. Okay? And medicine over the last 2,000 years had a lot of ways of treating people which made no sense and probably hurt them. There was a study done, or a former editor, I believe, of the New England Journal of Medicine was once asked, you know, how much has medical science and technology improved? So when was the year in which it was safer to go to a doctor as opposed to not go to the doctor? And his estimate of that was 1950, okay, which is relatively recent. And I'm not even sure that's the right date. We can sort of discuss this a little bit. One of the things doctors don't keep track of is when you go to them and they find something wrong with you and do a treatment that causes some problem later on, maybe you didn't need to be treated for that problem. And so the problems that result later on may have been a result of being treated for something that you really didn't need to be treated for. The point of this, it's very hard to assess when a medical treatment is being useful and when it's not. So, for example, for 50 years, 100 years, it was very popular to use leeches to suck out the bad blood from you if you had some disease. And they would put these leeches on and they would suck the blood out of you. Now, it actually turns out that a lot of these folk remedies have some basis in some sense, and leeches do secrete some chemicals that are actually useful for certain types of diseases. They're particularly useful if you have damaged tissue, because the leeches eat the dead tissue so it doesn't become infected and is actually useful in some ways. And they secrete other things that may stimulate the immune system. But basically, putting the leeches on you, if you like have a cold or something, or you have some other major disease, is really stupid and is not useful most of the time. And people did this for 50 years because it's very hard to assess when someone is getting better and when someone is getting worse and how you assess these treatments. So the randomized clinical trials were developed because we're so biased in looking at data that we need to look at the statistics and separate out different types of data to tell whether treatments are really working. And let me read you the quotation here about that. Again, this is from Thomas More's Deadly Medicine. The randomized clinical trial is the product of the strange and uncomfortable marriage of mathematics and medicine. The doctor believes all life is precious. In a clinical trial, lives lost and saved are measured coldly, counted like beans out of a bottle. The doctor learns to trust his clinical judgment, a developed sixth sense that incorporates but sometimes transcends the available and always inadequate data. The clinical trial demands the doctor treat his patients blindfolded, unaware whether he is providing a life-saving treatment or an inert placebo. The best doctors believe each patient is unique, deserving individualized treatment. The clinical trial demands strict adherence to standard rules and specific criteria. It is a wonder that doctors will participate in a cold and mechanical clinical trial. Some indeed do refuse. However, the short history of clinical trials has repeatedly demonstrated how often doctors' clinical judgment and best intentions were simply wrong. As Sir George Pickering, a British doctor and medical research pioneer, puts it, doctors' clinical judgments are, quote, victims of the freak of chance, end quote. Now, they're talking in terms of clinical medicine, but again, I think we face all these same issues in designing psychological experiments and all these issues of how we want to get data from the individual person doing the experiment, and how much of that individual data do we want to collect, and how much do we want to keep the experiment within the pre-assigned protocols. So I think we have the same tension here. And again, I think in doing an experiment, even if we have preset protocols, we want to look at what the person is doing, because maybe that will give us hints and clues and insights into the processes going on. But if we do too much of that, then we'll lose the statistical advantage of having an unbiased set of how we're looking at the data. Thomas More continues, the tension between mathematics and medicine dates from the moment a French doctor first started to count systematically results of treatment rather than to describe individual cases. And again, you can see the tension in terms of psychology, in terms of kind of modern statistical psychology versus Freud and Jung, again, in this sort of similar context. Early in the 19th century, Pierre Charles Alexandre Louis came to doubt one of the most major medical therapies of the day, bleeding or venesection. That's the leeches I was just referring to. Working before the discovery of germ theory, Louis found that bloodletting was more frequently employed in patients who died of typhoid fever than amongst those who survived it. His approach was opposed by other Parisian physicians who argued against such, quote, curious logical abstractions, end quote. They argued that simple averages from groups of patients should not be applied to complex individual cases. Since everyone was so different, a multitude of unique factors might well outweigh any gross conclusions derived from counting events in groups of patients. Louis' opponents argued that only the physician's clinical judgment is capable of weighing this multitude of seen and unseen factors in an individual case. It is an argument that resonates to this day. The doctors who helped develop these two drugs I'll describe in a minute plainly became aware of their dangers, but they believed in their clinical judgment. They believed they could select patients who could benefit and perhaps be saved. History teaches the error of that proposition. If the knowledge and underlying assumptions of clinical judgment are incorrect, then the physician typically cannot see the results of error, no matter how bizarre the outcome of treatment. For 1,000 years, physicians allowed infected wounds to fester, untouched because an authoritative Roman medical text had decreed erroneously that pus was beneficial to healing. Gross error, however, was hardly confined to medieval times. Paul Beeson, editor of the Modern Textbook of Medicine, once reviewed the 1927 edition of the same volume. He noted in particular the prevalence of treatments that were manifestly harmful, such as arsenic, which was recommended for 40 diseases of violent purgatives, which were prescribed even for the most fragile patients. So the point of this is that we face an interesting tension between how careful we do observations of people to learn about their psychological behavior and how much we don't want to trust these complex observations, but want to form things into specific groups where we can just do the examples in this cold statistical way. And as an example of this, I'd like to describe a little bit in more detail the example that this book, Deadly Medicine, is based on. And so I'll do that now. This is an example that goes back a few years. And it goes back, and I think it illustrates the problems we have in doing experimental designs and interpreting experimental data, and the psychological problems we have in dealing with the statistics in randomized events. And I described this a little bit in my talk in electrical engineering, which I think a number of you were at, but not everybody. So I'm going to go through it again a little bit. Basically, if we look at the heart beats in a way that looks almost regular. So if I plot the electrical activity of the heart, such as its voltage as a function of time, heartbeats look something like this. Now, these are actually pretty good. So even though I'm having a bad spelling day, I'm doing okay on the heartbeats today. And there's some structure in these heartbeats. What happens in the heart, if you could go to the camera for a moment, switch to the camera, thanks. and just tighten up a little bit. Thanks. The way the heart works, the heart is an organ shaped roughly like this. Not exactly like this, but roughly like this. And it's kind of unusual in that each cell of the heart can beat separately. So the heart beats all at once, not because, like a car, the transmission is connected to the wheels, but it beats because the fastest cells that beat will cause the other cells to beat with them. So a cell can either beat or stimulate other cells to beat. And the fastest cells beat toward the top right, actually, and that spreads the beat around the heart, so the top contracts and then the bottom contracts up. So we have a situation where the two ventricles, the two auricles, the two cells at the top contract, and then the ventricles at the bottom contract and push blood out. So if you can go back to the Elmo again, thanks. We have a situation in the heart where each cell is capable of beating. And in fact, if you take one of these cells and cut it out and put it in a little dish, and you want to put some nutrients in it, you know, keep it healthy, a little water, a little salt, keep it happy, a little sugar. By the way, you can run a heart for about 1 day on 1 can of Coca-Cola. So that's about the energy that the heart uses in 1 day is supplied by the sugar in 1 can of Coca-Cola. So I've had, if we put a cell isolated from the heart in a dish, any of these cells will beat, all by themselves. But a cell away from this one center, which is called the sinoatrial node, these cells beat the fastest. And cells further away beat slower, but they can be stimulated to beat. So if a wave of activity starts here, it will spread around the heart, contracting first the top of the heart, then the bottom of the heart. Then the wave goes up here, contracting these two main pumping chambers called the ventricles. And we can see that in this electrocardiogram, sometimes spelled from K for the German electrocardiogram. And this part of the voltage recorded from the heart is the wave spreading down, and the other part of this is then the wave reversing direction and spreading up. So again, we have this wave spreading down in the heart, and then since it turns direction in the body, its electrical voltage reverses sign and it comes up the other way. These are called, the different parts of this are called Q, R, and S. And one of the ways we can measure the time from one heartbeat to another, if that's what we're looking at, is the time from one R to the next R. And so the time from one heartbeat to another is very often called the RR interval. Okay. Now, there are lots of things which cause the heart to beat irregularly. One of the worst things that can happen is if this mechanism has failed for some reason to spread the pulse traveling around the heart in a regular way, what can happen within the heart is that we can have a bunch of little pulses, all of which are circulating. And under certain conditions, this will happen. And what this means is that each piece of the heart is going to be beating separately, and it's as if the heart is fluttering. So there's no organized motion, and the heart doesn't pump. And this is called fibrillation. And it's always described clinically, a heart in fibrillation is always described as a bag of worms, a bag filled with worms, because you can feel the individual squiggles of the individual pieces of the heart beating. And fibrillation basically leads to death because death. All right. In a few minutes, because the heart needs oxygen itself to stay alive, and if it's not beating, the heart itself is not getting oxygen, and the brain is not getting oxygen, so the heart will die relatively soon, and the brain will die relatively soon, within a few minutes. So this is a very bad state. When this happens, the way they fix it is by putting a big voltage across the heart and turning off all the cells, to then restart them in a rhythm that will be entrained again. So this is what a defibrillator does. And it sends a huge current to do this. So it turns off all of the cells, and then when they start, The ones here have a longer natural period, so if you're lucky, they'll be restarted by the fastest beating center up there, and then the regular pattern will be restarted. So it's interesting, in order to restart the heart in the right way, you don't have to tell each cell what to do. If you zap them all, they'll all be at the same point in their cycle, and so they'll all be ready to be stimulated by the fastest beat that comes by. Okay. So when the heart is beating irregularly, so now let me symbolize the heartbeat not by this entire QRS complex, but just by a simpler form. So I'll symbolize a heartbeat in time by just one pulse. If the heart starts to beat in a very irregular way in time, this can cause very severe problems, and in particular, if the beats are very rapid, it can lead to fibrillation, which would look something like this, and death. When the ventricles, the main part of the heart, beating very rapidly like this is called ventricular, for ventricles, tachycardia, which means rapid. So this is like the elevator stuff and everything else, right, and the ropes, because if you said rapid heartbeat, it wouldn't look official enough. So this just means rapid heart rate of the ventricles. And ventricular tachycardia, the rate can be 3 times what the normal rate would be, and that can lead to fibrillation. In fact, I may have mentioned at some point, maybe I haven't, that I'm working with a group headed by Mark Wood, who's in Richmond, Virginia. And what they do is they have patients that have a VTAC. So the jargon for this is VTAC. They have patients who have VTAC, and in order to keep them alive, they implant a little device in their chest that is a computer that counts the number of heartbeats. Whenever their heart beats 3 times the normal rate for 6 cycles, it zaps them and resets the heart into a normal rhythm. Now, it's also a computer, so it saves the times at which it did this. And we have the data from when one of these events happened to the next one, and we're actually studying them, and it turns out they have very fractal properties. And these devices keep these people alive. It's a very scary event to watch. A friend of mine who's a nurse said in a room that she was supervising, they had 2 patients, and one of the patients had one of these cardioverted defibrillators, they're called, and it's a very strong shock, so you go through a whole convulsion. And this guy wasn't converting, so he went through a convulsion. It waited, I don't know, 30 seconds or a minute or so, and he went again, and so it took 6 of these before he finally converted to a normal rhythm. The person who was probably the most freaked out was the guy in the bed next to him. But he did convert. So these devices are useful at keeping people alive, and also, as I said, we've been analyzing the data from these.
Is that what a pacemaker?
Now, a pacemaker itself, a normal pacemaker, is just a device that's put into the heart to create an electrical signal to start the pulse. So it creates it in a very regular way. There's lots of different types of pacemakers, some of which adjust a little bit to different conditions. But the pacemaker itself just sends a pulse through the heart to start the heart beating regularly. These devices are not really pacemakers. What they're doing is they're looking for when the heart is beating too rapidly, and they're depolarizing the whole heart. They're sending a much stronger pulse. So they're a much more stronger device than a typical pacemaker. And it's also interesting, people die from bad pacemakers. So if the program in your pacemaker fails, the pacemaker may not change in the right way, or may not be reprogrammable from the outside controller that's supposed to do it. I had a job interview once at Harvard Medical School in the cardiology department where I didn't get the job. But it was a bad job. I don't know who got it. It was bad because it sounded like it was a great job. It was a joint appointment at MIT and Harvard, except the deal was that the MIT people hated the Harvard people, and everyone thought you worked for them. So there was news about this job. But it was nice to go up for an interview. And this cardiology department at Beth Israel Hospital at Harvard Medical School was actually where cardiac pacemakers were invented, and very famous people work there. And to prove how macho they are, they have like grand rounds at 7 o'clock in the morning, and I was at one of the grand rounds they did. And they had a patient who was going to die anyway, but who had a pacemaker where the program had failed. And they had to decide what they wanted to do with this patient. The patient was dying because her heart wasn't beating. But on the other hand, she was so sick that going in to reoperate to replace the pacemaker was probably not a viable option. And I think she died. But in this case, the pacemaker had failed. But in her case, the underlying disease had progressed to such a point that the failure of the pacemaker really didn't make any difference. So there are some problems in software and how the pacemakers work. On the other hand, I mean, the number of lives that have been saved by this and tremendously outweighs the problems they've had with this. So this is a very good, very useful technology. The chief problem with this was not the pacemakers, but was the interpretation and the unwritten assumptions in terms of paradigms that I mentioned before. And let me discuss how that comes into play here and how this relates to the randomized clinical trials. So what I'm trying to do is to tie together several different concepts here from the very first time where I talked about paradigms in science and how we approach science and how we need these randomized clinical paradigms to overcome the problems that we sometimes have and how we set up experiments. It became clear that people that have very irregular heart rates tend to have a lot of problems and will result ultimately in cardiac failure and death. So it became kind of dogma or the paradigm to believe that the heart should be beating as regularly as possible because when it was strongly irregular, people died. Okay? But this led to something. It led to people thinking that it's best when the heart beats regularly. So when people started to see irregular rhythms or very irregular rhythms, drugs were developed to treat the irregular rhythms. But what was happening with these drugs is they were also given to people who had only slightly irregular rhythms. And this goes to the clinical judgment that I was just quoting before. If you know that someone who's about to die in a severe irregularity, if the drug helps them, if you see someone who's a little bit irregular, maybe you should give them a little bit of the drug to make them more regular so they have less of a chance of dying. The particular irregularity that was involved here were premature ventricular contractions. And on the heart record, that would look something like this. So every once in a while, there's an extra beat. So the ventricles sort of just all by themselves, every once in a while, you can see here and here, a beat when they're not supposed to. So this, and it happens early in the cycle.
Is that what we call a heart murmur?
No, a heart murmur has to do when the valves of the heart don't properly close and blood leaks back and cause a little gurgling sound, which is where the word murmur comes from. So it's not related to a heart murmur. There were other problems involving the valves in the heart. The heart basically has 4 chambers, and these two are connected. So there are valves here and also here and there. And I guess the most likely valves are this one and I guess this one that have problems, and I'm not sure. And that's involved in a murmur. So this isn't like that. These were called PVCs for premature ventricular contractions, or sometimes VPCs more recently. And a series of drugs were developed to treat these PVCs, to reduce them in patients. Again, the drugs were now given to patients who had severe, or let's say frequent, PVCs. But they were also given to patients who had few, again, because it seemed reasonable. And this is, again, all described in this book, Deadly Medicine. And I also know some of, I know actually a number of people described in this book, because some of these people are at Columbia where I was. And I know other people who know many of these people better than I do. And what's very good about this book, again by Thomas More, what's very good about this book is a description of the politics of science, or of medical science, and of personalities. A lot of these people are important and arrogant. And a lot of these people have connections with drug companies. And it's not that the drug companies are buying people off or anything, but you get into believing into yourself a little bit too much and carry a little bit too much weight. In fact, one of the people who noticed the problem early on here, who was not at a second-rate institution, but was at Stanford, and was not an unimportant person, who was maybe an assistant or associate professor, but the warnings that he tried to get published about problems that he saw were rejected for publication. He was just sort of pushed out of the group of people who were the players in this field. And this book describes very much the politics of how science and medical science is really done. It's very well written and very accurate in terms of the personalities of the people I know, in terms of the personalities that other people who know better these people know. So I think it's very worthwhile to read, to give you a sense of what really goes on in medical science. Well, in any event, they gave these people these drugs, and no one ever tested, there were no randomized clinical trials whether these drugs really worked or not. Finally, they set up a clinical trial, which was called CAST, for the cardiac arrhythmia. I can spell arrhythmia, but not death, apparently, today. Suppression trial. When I lived in Boston, I typed it enough so I could spell Massachusetts. And this was called the CAST study. Now, this study was a very large multi-center study involving a number of patients. So the number of patients here was much smaller than the total number of patients receiving these drugs. Number of patients involved here is roughly about 1,000 patients in this study. Number of people receiving these drugs was about 2 million. Okay? So this is small. It's a big study, but small compared to the total number of patients. As I said, it's really important to do these studies blind so the patients don't know what they're getting. I quoted before the description of cardiac patients who received drugs that were placebos, where it cured, medically cured their heart problem. And this was also double blind. Okay. Let me show you how well matched the placebo and the treatment group was. This is some of the statistics from the study. Both in the placebo group and in the control group had roughly the same, widen out to my fingernail, had the same number of smokers, the same number of people with chest pain, same number of people who had cardiac bypass surgery and previous cardiac arrest. You can see they're mostly males. Most of the heart work in studies have been done on males, which is sort of silly because women have about as many heart attacks as males, but it's always white males in the white lab coats who give out the money. Number who have taken other drugs. Ejection fraction is the amount of blood pumped by the heart on each cycle. This is one of the things that starts to go down when the heart fails, the average age, and the number of premature ventricular contractions per hour is about the same in each group. Now, there was one person who was responsible for keeping track of who's in the experimental group and who's in the control group in this study, so they know which drugs people are getting. And this all gets locked up in a safe somewhere. It's all very official, and you have to keep very careful records. And this is what they saw in the group, in the study. In the X group, there were 3 deaths from sudden cardiac arrest, from heart attacks. And in the Y group, there were 19 out of roughly the same number of patients. So you can see that the number of patients in this Y group, or the rate at which these patients die, was very statistically significantly, we can't see from here, but it was very statistically significantly larger than this group. And at this point, they decided to pull the study because the Y group were the people who were receiving the drugs. Okay? So at this point, they made a very big stink about this because, you know, they were killing people and good physicians can't kill people, so they needed to cancel the study. Again, this is a study only of 1,000 people, and 2 million people are getting these drugs. So to me, maybe continuing this a little bit longer to get more statistical accuracy might have been justified. They didn't feel that it was. Now, the point of this study the problem here was not so much that the very sick people were getting these drugs. The reason why 2 million people were getting these drugs is people who were not sick were getting these drugs because their hearts were beating irregularly every once in a while. And because the paradigm was if you beat a little irregularly, it's not good for you. But no one had ever tested that, and no one had ever tested that in a controlled statistical way. When it was tested, it was found that a little irregularity is not bad for you. In fact, suppressing the irregularity caused problems. Now, there are several appendices in this book where Thomas More tries to make an estimate of the number of people who were harmed by getting these drugs. Remember, if you have a drug that has some side effect, if you give it to a population of people who are mostly well, even if the percentage is small, the number of well people you're going to hurt is going to be very large. And that's exactly what happened here. The estimate from Moore is that, which I think is very convincing, these drugs given to basically well people killed 50,000 people a year. Okay, so this is pretty significant. This is more people than, a little bit more people than get killed in highway accidents each year. So this is very significant. And no one had realized this, because just your own clinical judgment in following each individual patient and trying to do the right thing by each individual patient isn't good enough, because you're easily fooled by what you're expecting to see, by adjusting the treatment to each patient, by knowing that if you see something that doesn't look right, you ought to help them, and not keeping track of the statistics. It was only by doing the statistics, by having controls, by doing a blind, by doing a double-blind study, that people realized that the statistics showed that this was really hurting people. Now, what was the response of the clinicians to this? Let me read you some of the description of what the response was. Quote, physicians have been angry about the news coverage when this was released of the cardiac arrhythmia suppression trial, CAST, reported Medical World News. In Detroit, cardiologist Felix Rogers told the Free Press, "We have received a phone call from probably every patient who is taking either of these two medications." In Iowa, one cardiology group practice in Des Moines reported 100 phone calls the first day, because now people knew about the results of these studies. It was no more tranquil in Florida. It's a mess. There are so many people on these drugs, it's unbelievable, cardiologist Scott Pollack told the Orlando Sentinel. In West Palm Beach, cardiologist Robert Chait told the local daily, "This is the most irresponsible thing to have done, to let the media know about it before the physicians. It's like shouting fire in a crowded theater." To Chait's kind of complaint, the Food and Drug Administration had a simple enough response. Spokesman Bill Gregg told one newspaper, "If you have something that is killing people, you can't get the information out quickly enough." In short, there really was a fire in the theater. A sampling of how physicians handled the patient calls can also be seen through the local and medical press coverage. One response was the classic physician assurance. "These two drugs are very, very good drugs. Not perfect, but basically good," said Jacksonville cardiologist Scott Baker. "If you select patients for the drug carefully, you're not going to have problems." In California, Ronald Miller told the San Diego Tribune he did not intend to take any patient off of Tambacor or Encade, which are the names of these drugs, but would schedule appointments anyway to put them at ease. Other physicians seemed oblivious to the message of CAST, at least in published comments. One important lesson from CAST was the danger of physicians using drugs for purposes that were unproven and therefore not yet approved by the FDA. Again, these patients who had mild PVCs. One doctor wrote FDA Commissioner Frank Young, "I have received approximately 20 distress calls from patients and an equal number from equally distressed referring physicians and colleagues." In the next paragraph, he told Young that he was mainly using the drugs for an unapproved use for which no safety data was yet available, for rhythm disorders of the atria, the two small upper chambers of the heart. "The FDA advice runs counter to our experience," he concluded. Based on the same kind of uncontrolled patient experience, Tambacor had seemed equally unsafe to Joel Morgenrath and numerous other experts who had touted it for suppression of premature ventricular beats. In Florida, the Orlando Sentinel quoted a cardiologist saying, "The drugs have been very effective in treating atrial arrhythmias with few side effects." That's for which there's no data. He told the paper he may decide to keep those patients on the medication. The fact that Tambacor had been proven lethally dangerous in one mild rhythm disturbance did not deter this doctor from continuing the drug in another mild rhythm disturbance in a setting where safety had not been established. Still another doctor told the San Diego Tribune that no indication was found of danger for the many arrhythmia patients who have never had heart attacks. Yet CAST had not found heart attack survivors uniquely vulnerable. They were simply the only patients who happened to be included in the study. Others attacked the new restrictions on the two drugs. An angry Idaho cardiologist wrote Young saying, "The knee-jerk response of withdrawing the indication for Tambacor and Encade in the treatment of patients with ventricular premature beats of other than a life-threatening nature makes no scientific sense at all and does nothing but promote hysteria among patients who've been safely taking the drug all along." So the lesson of this story was first that just qualitative reasoning, so just qualitative experience, let me say it, actually it's important enough to write out, even if it doesn't get spelled right, that qualitative experience was not enough to see what was going on. That we needed this more abstract and cold, first of all, protocols, and both blind and double-blind experiments set up in a good way that we then analyze the statistics. And what I'm dealing in this course is statistics and to a lesser extent experimental design. That this is what was necessary to see what was really going on in these experiments. And second of all, when told the results, when the results were clear, these physicians just didn't believe it. Because we have a strong sense of what we want to believe and what we don't want to believe. Now, I don't mean here to be picking on these physicians. And I think the problems that face the physicians face us. And these are problems that we need to deal with in the experiments that we perform all the time about this tension between learning from subjective judgments, which are crucial, judgments probably as an E, that we learn from and give us clues and insights into what's going on, versus being fooled easily by those judgments, which is why we need non-subjective protocols. In terms of these experimental designs that I've described at the beginning here today, in terms of the between and within, in terms of the carryover effects, in terms of the confounding variables, in terms of this experimental design, and in terms of the statistical analysis, to look at the data, to understand when this is happening or not. And this tension between these two different things that we need to do is a very strong one and not a simple issue to resolve. And what I'm trying to show you by this medical example, which has tremendous consequence, which over about 5 years, we're talking about 250,000 people who are dead, which is a very significant number of people. That was a failure to understand the importance of doing these experiments in these blind and double-blind ways and making the statistical analysis. On the other hand, that doesn't mean we just do experiments where if we see people behaving in a certain way, we don't learn from it. And we need to keep our eyes open and see what's going on in the experiments all of the time. And so it's not that we want to completely cancel out our subjective judgment, but we have to realize its own limitations. And it's very easy for us to fool ourselves. And the physicians are in a position where they're really trying to help people, and that they're really trying to tailor things to the individuals and trying to use their individual experience and their insight. But as you can see from these quotations, that they fool themselves. And it's very easy to do that, and it's very easy to do that in analyzing our own experimental data. So in a course like this, in terms of methods that we use, I want to deal not only with the statistics, as much of the course will deal with, but give you a sense of these issues that come up in the design of the experiments and in our relationship to our own psychology and how we handle things. That we are just as human as the subjects in the experiment and have just as difficulty seeing things and can give them clues about how we want them to respond. And we have to be very careful about segregating out those issues and sometimes dealing with these non-subjective protocols and really following these issues about blind and double-blind religiously sometimes in order to make sure that the result we have is really a substantial one. And that's why I've gone through this whole long medical example to give you some of the details of this, because I think it's interesting to see an example where this happens. The last thing I just wanted to touch on very briefly is that other issues that come up in terms of design of experiments are ethical issues in how we handle the subjects in the experiments. And I'm not going to have really time to do this in depth, but I will run through it very briefly. In all experiments, if it's human experiments, need to be approved by an institutional review board, and in terms of animal experiments, by an institutional animal use and care committee. So these are for humans, and these are for other animals. And in general, the rules in terms of the American Psychological Association for handle human experiments are, and you should read these in the APA, American Psychological Association manual, are first of all that the experiment should cause no physical or psychological harm to the subjects, and that the planning of an experiment should involve ethical considerations. In planning a study, the investigator has the responsibility to make a careful evaluation of the ethical consequences. The investigator is responsible. The investigator retains the responsibility of ensuring ethical practice, and in fact to make sure that all the collaborators, assistants, students, and employees are also responsible, as equally are those assistants, students, and employees responsible. We need to have informed consent to make sure people know what's going on. And how you do this where you're trying to deceive them a little bit or keep them blind about which group they're in raises lots of interesting issues. You have to allow a person to withdraw from the experiment if they want to. And that causes real problems because now we're not randomized in the different groups anymore. But the experimenter must respect the individual's freedom to decline to participate if they want. It may be necessary to have a follow-up session if you fool them into thinking, for example, they're in a situation where they're more stressful to measure a stress response. You must make sure afterwards to remove any misconceptions that have arisen and make sure that they have no lasting harmful consequences. And you must protect their confidentiality. Whether we can do this legally or not is not clear. Recently, the Tobacco Institute sued for some records of subjects in experiments about smoking, and whether we can and the court actually granted them that information. So whether we can legally actually do that is not clear. So I've just, very broadly, given you what are the most essential elements of dealing with human subjects. This is not meant to be comprehensive, but you should read the ethical guidelines from the American Psychological Association and realize that as an experimenter, you are required to make sure those are met in an experiment. And as a student, you should also be aware of them, make sure that you understand that you have those responsibilities as well. So I wanted to at least mention that in passing. If you have any other questions or comments, I've covered a lot of sort of different issues in terms of this. Okay, what we're going to do next time is I'll go over the homework that I handed out today, and we're also going to get into statistical tests to how we look at the differences between the experimental and control groups and how we tell if there's a difference or not. We'll start off first by doing parametric statistical tests, that is assuming that things are Gaussian, and also next time how to do a chi-square to fit to see if it really was a Gaussian. And then in the week after that, we'll go to non-parametric tests that don't assume that things are Gaussian. So we're going to start with all the standard statistical tests, the t-tests, and the guy who wrote the t-test worked for whom? Guinness, right, good. So we're making progress. And we'll continue not next week, but in 2 weeks from now.